That's right.
Thank you. I'll let them in now.
I'll share my screen.
Sounds good. All right. Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Memon. Dr. Memon is a general pathologist working at Mackenzie Health and the Wuhan Hospital in Canada. She has a special interest in hematopathology, digital pathology, and AI. She's also the physician lead of Hospital Transfusion Medicine Department at Mackenzie Health. Dr. Memon completed her residency training in general pathology from the McMaster University in Canada and attained a Master of Science in Laboratory Medicine and Pathobiology from the University of Toronto. She serves as a chair of general pathology section at the Canadian Association of Pathologists, the CAP-ACP, and serves as a clinical assistant professor at McMaster University in the Department of Pathology and Molecular Medicine. And now it is my honor to introduce and request Dr. Memon to begin today's session. Thank you.
Thank you so much, Manahil. Good morning, everybody. Thank you so much for having me. Thank you, Dr. Khurram Siddiq, for inviting me to share my experience with all of the attendees over here. So Manahil, you've given me such a good welcome. So I don't know what else to add, but I'll still add a little bit about me as well. Let me share my screen. Okay, are you all able to see my screen?
Yes.
Okay. Just all right, I just have to exit the minimize the Zoom video. Sorry for the technical difficulties that I'm having.
No worries, take your time. And we're able to see the slides perfectly. I think it's just we don't see Zoom, so that's also
okay. That's great. All right, good morning, everyone. So my name is Sadaf Memon. I'm the staff pathologist and physician lead at Mackenzie Health, Ontario, Canada. I also serve as a chair of the general pathology section at the Canadian Association of Pathologists. And I'm also the clinical assistant professor at the Department of Pathology and Molecular Medicine in McMaster University, Hamilton, Ontario. So a little bit about me. I did my medical school from Dow Medical College, now called Dow University of Health Sciences, Karachi University. And after my medical school and house job, I came to Canada and I started working as a researcher in the Department of Pathology. From early years, I was very interested in pathology and wanted to explore a bit more. So I did some research about a year or so in hematopathology, where I have a few publications early on. And then I entered and did my Masters of Science in Laboratory Medicine and now Pathobiology from University of Toronto, Ontario, Canada. And after finishing all my medical licensing exams, I entered residency and I did general pathology residency training, which is the counterpart anatomical and clinical pathology in US. So our program is 5 years instead of 4 years, which is in US. So I have special interest in hematopathology and transfusion medicine. My practice includes all the general surgicals, along with hematopathology, bone marrow aspirates examination, and transfusion medicine. Other than that, I also am the nucleus member of the Royal College and of Canada in the general pathology section as well. So at any time during the talk, if you have any questions, you can put it in the chat box. You can raise your hand, ask questions. You can direct that to Manahil, Dr. Siddiq as well. And or if I will leave my email as well at the end if you wanted to ask any additional question, any other guidance, I'm more than happy to help anybody. Okay, so let's begin the talk. So the title of my talk is Not Only the Future, but the Current Practice of Pathology Should Be Digital. So I have no conflict of interest and no financial disclosure. The latter part of my presentation would cover protocols which are used specifically at Mackenzie Health, the organization that I work, which may or may not be generalizable to other institutions. Of note, digital pathology implementation is institution specific, and there is no one size fits for all kind of approach. So what is the background? What actually digital pathology is? So the history dates back, as we all remember, we all know that how radiology was. You used to have handheld films, you put it, and you will go to your doctor's office and there are handheld films. They started actually converting them into electronic imaging system back in 1996, and that was implemented for ultrasound. And in the year 2000, the opening of the new John Hopkins Kimmel Center building included a picture archive and communication system, PACS, which everybody is aware of, that covered all modes of imaging. So similarly, digital pathology was developed decades ago to enable pathologists to remotely collaborate on cases and improve diagnostic accuracy by sharing their digital images across the lab. So the guidelines for validating whole slide imaging for diagnostic purposes in pathology was first published in 2013. So at the end of the presentation, you'll see my references as well. So that's an excellent paper to explore and to read if you all are interested in knowing more a little bit about digital pathology. But I promise you at the end of this presentation, you'll know something about digital pathology. And the College of American Pathologists, the Digital Pathology Expert Panel, they convened to update the 2013 guidelines to develop convincing and accurate clinical practice guideline. So the organization where I work, Mackenzie Health, we are the first in Canada that has adopted digital pathology as the main, our main source of diagnostics in our pathology practice. So what is a traditional pathology practice? As we all know, and also for the medical students or the undergrads who are interested, and I'm sure I will convince you all to take pathology as a future specialty and consider it. And I promise it's a very good specialty. So the traditional pathology practice, as we all know, it's like mounting samples on the glass slides and viewing them under the microscope. But preparing this glass slide, it's not very easy, my friends. So basically, the sections that we received for the tissues, basically the microscopic analysis of cells and tissues requires the preparation of very thin, high quality sections, which are mounted on the glass slides and appropriately stained with H&E and hematoxylin stain, NeoSyn stain. So most tissues that we received or retrieved from the patient's body, they're very delicate, and they can be damaged and impossible to prepare thin section unless they're chemically preserved. So there are two ways of preserving the tissue. We can either freeze the tissues and keep it frozen while we cut our sections. Those are called frozen sections. Alternatively, we can infiltrate our tissue specimens with a liquid agent, and that can subsequently convert into a solid, and that has appropriate physical properties which will allow sections to be cut. So those are the paraffin fixed tissue, or the paraffin wax is such an agent that will fix the tissue. So the top left image, you see those are the paraffin embedded tissue. So whatever the biopsies, whatever the sections that we cut, we prepare them in the blocks, and these blocks are there, and they they can stay forever. And so each hospital and each countries have their own guidelines in up to when they can put it. But for the glass slides, the retention is 20 years in Canada and 10 years is in United States. So this complex process, after that, once these blocks are prepared, the bottom picture that you will see, we would basically thinly slice and cut them. And then the picture A, you'll see how these thin slices are done. Then these are adherent on the glass slides. And then they are fixed. There are several processes that would occur. You put in alcohol, xylene, after staining, and then this is what you see basically on the slide. Then you slide them under the microscope, and you see what you're actually looking at, what the clinical question is, and you diagnose it. The digital pathology practice, which I wanted to convince you all today, is these microscopic glass slides are still prepared, but instead of using the microscope, the right side, you will see this is the image. This is the image from Philips, the software that I use, and the digital pathology solutions that we use at Mackenzie Health. So I'm not marketing about Philips, but just to let you know, as the picture is taken from there as well. So all the digital slides, you can see on the right-hand side of the image that this is a digital pathology solution in the scanner. So all the slides will go into that scanner, and they are scanned, and then you can see them once it's interfaced or integrated with your laboratory information system, which is called LIS. So as you see your images in radiology, similarly, you'll be able to see all your case-related images attached with the case, attached in patient's chart, and you can diagnose. So we no longer use a microscope. They're still in our offices, but we no longer use it for a primary diagnosis. So basically all our slides, they get scanned into this digital scanner, and then we see them in the computer, and these images are retained there in our computer. So the microscopic glass slides are increasingly replaced by digital pathology whole slide imaging WSI platform, which converts the glass slides into high resolution computerized images at various institutions and organizations across the globe. So how did we land it in digital pathology? So as we all know that COVID has taught us many things. Because of COVID, I'm doing Zoom, and many things that were not possible before, now it is possible. And COVID has taught us a lot of good things, as well as how effectively one can use their time. So before COVID-19 pandemic, the United States lagged most of the other developed countries in terms of digital pathology adoption, due to the strict federal regulation of US FDA and CLIA from the Center of Medicare and Medicaid Services. So FDA relaxed some of the requirements to approve and validate digital pathology related technology to meet the pandemic needs. So similarly, CMS waived restricted CLI rules that now allow the pathologists to use the digital pathology platform from home. So I can show you how we work from home as well, along with working from our office workstations as well. So thereby, COVID-19 pandemic, it accelerated the broad adoption of digital pathology for remote rendering pathology diagnosis. As we all know that during the COVID, there were a lot of absentees in the department as well. It was incubation period. The world was going through so many changes. So the digital pathology platform actually assisted us as pathologists to still diagnose for a patient by staying at our home workstation or staying remotely, and diagnose our cases and produce diagnosis in a timely fashion. So we are not jeopardizing the patient care as well. So what is the digital pathology landscape in 2023? So a major rethink has occurred over the last 2 years of the COVID pandemic. Labs around the world have successfully gone digital, and enabling functions of digital pathology platforms the benefits are beyond the laboratory. So what are the benefits? So because once these slides are scanned, so the images are actually in the computer, scanned, and you can actually share those images of those patient information with the appropriate institution who are also involved in the patient care. So you can actually send your cases for consultation, right case to the right pathologist at the right time. So if you need any expert consultation, you can actually share your images in encrypted files, and that could be easy, and you can obtain consultation quite easily instead of actually shipping the glass slides, paying for all these costs of the shipping and handling. You can do it with one click of the mouse. Obtaining expert opinion and consultation, because of course you do need some, if there is a difficult melanoma case in which you really wanted an expert from a dermatopathologist. So as a general pathologist, you'll be sending it to the derm path. For example, if you wanted to do, you wanted to request another expert opinion for hematopathology group, so you can actually transfer the slides. And instead of transferring the slides, you can actually share your images. The key is the other department who is actually looking at your slides, they should have this type of software as well. So both the specialties and both the institutions should have this software in order to adopt or to give consultations as well. So qualitative and accurate, precise imaging analysis. So we as pathologists, when we get the samples from the patient, for the breast cancer, for prostate cancer, for urinary bladder cancer, we are asked how far it is from the resection margin. What is the grading of the cancer? What is the scoring of the cancer? The Ki-67 proliferation index of the cancer. So all these are done very effectively. I'll convince you with all the images later on in this presentation. It's the best education and research platform. So we can teach undergrads, medical students, and pathology residents very effectively with these tools. Instead of calling them and asking them to see into the microscope, you put all your heads under the multi-head microscope and start looking at it. And with this technology, you can easily teach the residents, the medical students, the undergrads, and do national and international talks like the way I'm doing it today. It's an excellent platform for artificial intelligence and AI tools, because the main requirement for the AI tools is you have to have all the images in the digital pathology platform. If you have that base platform, you can actually explore that avenue. I'll talk a little bit more about it in the later part of the talk. It also saves the cost of shipping and handling. As I already mentioned to you, that instead of shipping and handling, the glass slides delays the turnaround time. If you're sending it internationally, it's going to delay further. So this is possible with this. It generates revenues as well, in the sense that it's time saving and efficiency driving measures. You don't have to hire the pathologist to come and be in your organization to work for you. You can actually see cases from your own, if you're in a different country, you can even work for the other countries as well. If you know this technology, if you know how to use this technology, you can actually help different countries as well who don't have expertise. And also within your same country, if there are some remote areas where pathologists usually they're not available over there, and so they could actually assist and help and get good paid as well to do the consultation for the digital pathology and sign out the cases the way they would do on the microscope. So Mackenzie Health is the place where I work. So it's Canada's first smart hospital. So we have completely replaced our microscopic glass slides interpretation to WSI, whole slide imaging platform. And for our WSI platform, we follow the College of American Pathology clinical practice guidelines, and we have successfully validated the platform. So here we are. So we are a two-site community hospital model, over 900 beds. We serve over 500,000 people population in Richmond Hill, Ontario, and Vaughan. So the newer site, which is the bottom one, is just across Canada's Wonderland. So this is the site where I actually work. This was built in 2021. And the Mackenzie Health Richmond Hill site, which is our oldest site, still there. It was built in 1963. So basically, these two hospital site model that is a place where I work, and so all our hospitals, all our pathologists are actually in the newer building now, and all our cases are scanned from Mackenzie Richmond Hill site, and at one site where we actually see all our cases. So we are 8 pathologists now. We are 9, and we see 22,000 surgical cases that were accessioned in the year 2022. So how our journey began? We began in 2018 with the start of the discussion, and the site visits occurred, the commercial discussion, the internal stakeholder discussion. We started the validation process in 2019. We finished our installation in 2020, and the pathologist office were set up for digital pathology. And this is how we went live. So this is a long process. The main reason for showing you over here that, you just cannot, get the technology and boom, you can start working on it. It cost a lot of money. It cost a fortune to do this. So initial challenges, like any department would have, like, I don't want to give up my microscope. It's not my microscope. It's unproven. It will slow me down. It will threaten my job. What's the point? What's in it for me? Why should I do it? So those were sort of initial challenges that we even had in our department as well. And for the institution, the main challenges are like the cost. It is way, way too expensive. And actually for the community hospital like us, you're thinking about $3 to $4 million. And of course, if you're serving like the whole institution, then you're looking, my friend, somewhere in $1 billion. So the disruption to traditional workflows, no guidelines or best practice recommendation. Those are some of the initial challenges, and lack of the regulatory approval, medical legal concerns. Will I be sued by someone if I diagnose something on digital pathology? No, that's not the case. So the methods and steps we acquired. So any department who wanted to implement digital pathology, they have to do their pathologist training first to teach the software, to how to use it, to do the validation. We have to train our lab staff to do the dedicated scanning. The IT support, one has to have an excellent IT support, because if the technology fails, if your computer is not working, if the it involves a lot of processes. Setting up the home office workstation so we can work remotely. We have to do all the validation processes. We have to follow all the ongoing quality management processes, which includes the SOPs and giving proper feedbacks to all our lab staff and all. So these are the two scanners that we have at Mackenzie Health. We're getting the third one as well. So we leverage the existing multi-system contract with Philips. So there was no RFP required for us. As you could see that all these slides, once they get scanned, and over here, this is the example of, it's a GI biopsy, and you see how it is integrated into our LIS. And once you click, you will be able to see like, okay, this case has 3 slides, and I can actually zoom in, zoom out, and start functioning as if I'm looking at my microscope. So in addition to our digital pathology, for the permanent section, we also have MRH frozen section, the Mackenzie Richmond Hillside frozen section. So as I told you, that our oldest hospital doesn't have on-site pathologists. So if there are any frozen section, what are frozen sections? Basically, when the patients, they go in the OR and the surgeons wanted to make sure that they're cutting a tumor or a mass, and they wanted to know if they are cutting it properly or not. Is there any tumor left in the body, to see the margins is clear or not? So we get sections as pathologists everywhere. So, to know the margin status, the patient is still in OR under anesthesia. We as pathologists, our job is to help our surgeons and to actually quickly make the frozen sections and look it under the microscope and see if there are tumor cells or not. We say, and we help our clinical colleagues and surgical colleagues saying that, yes, the margins are clear, then they would close the body. And basically, that's how the surgery ends. And if the margin is not clear, the surgeon would go ahead and take further more sections. So these are basically what the frozen section is. So in terms of frozen section, we also have, used Sakura Vision Tech, and it's a Japanese company. Basically, our frozen section, we also completed another validation study. So our frozen section are also through a live a digital microscope. And basically, this is how we do our frozen sections as well. So this is my office home workstation. As you could see that I still have a microscope on the right-hand side of the screen. And these are the 3 digital screens. The left screen is basically for any emails check, or your own references, or whatever you wanted to do. The middle screen is the middle barcode monitor, where all my images would appear once. And then on the right hand side of the screen, I use that as my LIS. So all my patient charts and everything. So all these images are attached to the patient's chart. Once I open it, I will be able to look at it on the bigger screen where I would diagnose it. The microscope is still there because the bone marrow aspirates, the peripheral blood smears, they are not digitized. So that's why, because I see most of the bone marrows in my department, so I still use the microscope for the bone marrow aspirates, but the biopsies, I still look at it under the microscope, under this digital pathology. We did a validation for the home workstation as well. And basically, what I did, so this is our home workstation. So this is my office, and this is the one that I'm currently working right now. And I'm giving the talk as well. So I have 2 screens, so there are no third screen. I don't have a third screen because I don't need it. Over here on the left-hand side, I will do all my LIS. On the right-hand side, I do all my images, and I see all my cases through that. I don't have a microscope in my home workstation, so you can see that because I don't need it. The reason how I did and made myself comfortable is basically I look at my cases under the digital pathology platform at home workstation. I put my diagnosis in the LIS system, and then I went back to the office the next day and look the same case under the microscope and see if I made if anything is different in my diagnosis on the microscope versus on the digital pathology. So all our pathologists, we were supposed to do 40 cases like this and to see if there is any major concordance, minor concordance, or the diagnosis is the same. So that's how we tuned our eyes. That's how we completed our validation study. That's how we went live. So this is the way what we do. So so we have started and completed our validation and developed our home workstation back in December 2020. So ongoing quality management process, standard operating procedures were followed. We don't have any IQMH guidelines. That's what we follow. And so we follow the American of College validation and proficiency testing system. And the pathologists were provided the opportunity to comment on the quality of the scan slides. So currently, digital archive retention, so basically like, okay, all these slides are scanned, they're in the patient's chart, how long you wanted to retain that. So as I told you, that the retention time of the glass slides for Canadian pathologists is 20 years, for US is 10 years. So for the digital pathology, because we are fairly new in this, 2 years, we are 2 years now, and it's still 8 more years to go. So our plan is to retain the digital pathology images for 10 years with backups, and we are using on-premises instead of clouds. So digital pathology and histology, they are closely connected. If your histology is poor, your sections are poor, your staining patterns are poor, your images and the quality would be poor. So it has to be the slide preparation and all these have to be perfect in order for your digital pathology platform to be really perfect. So we also did the post validation to full adoption. So the full adoption occurred. So we started in 2018 with everything, the purchase of the instruments, the validation, the 2020 December when we put our home workstation, May 10, 2021 was the time when our last pathologist asked to stop receiving glass slides. So all our pathologists have successfully converted to digital pathology from microscopic glass slides. So now you can see on the left side, this was January 2nd, 2021, and this is May 11, 2021, the right side of the image. Over here, you can see that until January, the glass slides were still delivered to us. And now, even right now, our cubbies on the right-hand side are like this because we no longer need glass slides, because whatever we see it under the digital whole slide imaging platform. So the outcome, we divide into pre-analytic, post-analytic, and post-analytic. For the pre-analytic, the outcome in terms of lab and admin staff, that digital pathology is faster, it's cheaper, and it's easier for the lab and administration staff. For the pathologist, as you remember that I said, the opinions of the pathologist were, it will slow me down. Their opinions change, works for me. It disrupts my schedule. Even that cohort of pathologists, their opinions change, it works for me. What's in it for me? Their opinions also change, work for me. I was a green one right from the onset. I said it works for me. But everybody has their own learning phase, their own curve, their own comfort level. So there is no race. People will be used to it once they use this technology. So it's not rocket science, to be honest. Post-analytic for clinical staff and patient, which is the important parameter. The follow-up appointments were kept as scheduled because people think that digital pathology will slow you down, but that is not the case. So actually, during the Masters of Healthcare Management Studies that I did from York University School of Business in April 2021, I did a project. And during that project, I actually looked at the assessment of the digital pathology adoption rate, the efficiency, and impact of the transition to digital pathology in a large community hospital. So I looked at the turnaround time data. So this is a very busy chart, but in a nutshell, I want you to just focus on the number 7 over here. So our turnaround time remained 7 days, even 5 to 7 days before the implementation of digital pathology and after the implementation of digital pathology. So we did not increase our turnaround time, but we're getting more and more faster in this technology, because if you're using this new technology, you don't want your clinicians and your surgeons and or the oncologist to be waiting for you. Dr. Memon, I'm still waiting. Are you still, testing and trialing your digital pathology? No, you want your patients to get your diagnosis in a right and in a timely fashion. So, the fear that the pathologists, we as pathologists, we had that this will slow us down. But I did this study along with my department and the management team and the department chief. So basically, we looked at the data and we found that the digital pathology turnaround time as compared to microscopic glass light interpretation was almost nearly the same. And now it is decreased, so that means it's even faster. So I've shown you a lot of black and white. Let me show you a few colors, and this is why I love pathology. So these are the scanning power, and I know they're a medical student, but I wanted to convince all of you that pathology is really, really interesting, and each day is new for me, and each day is really, really exciting, because what we see under the microscope, because we play a pivotal role in patient management, and because we are physicians. We are actually guiding our clinical colleagues and providing them gold standard answers. So I really like being called that we are gold standard, and we are guiding our clinical colleagues with the questions, because the radiologists, they see all gray and black and white. And they would say, yes, there is a nodule, there is a mass. But we as pathologists, we look the cases under the microscope or the digital scan slides, and we say, no, this mass is actually a cancer. Or no, this mass is actually not a cancer, but actually a benign entity or inflammatory disease. So even for the internist, for the oncologist, we basically provide them with all the information. For the oncologist, we provide them all the grading, the staging of the cancer, and then that direct the patient therapies. And for the internist, if they are looking for a mass or a tumor, so we are not doing any sort of guessing games. We are actually giving them the gold standard diagnostic answer by looking at the case under the microscope or digitally scanned slide and giving them the right answer. So that is the job of us as a pathologist. So this is really, really exciting, because we are not doing any sort of guessing games. We are behind the scene doctors. Our names, some people would think, oh, send it to pathology, but who is working in pathology? We are the physicians, we are the pathologists, we are the doctors who are working day and night for the patient. And so at times, I do call my patients as well if there is some kind of explanation which is required as well. I sit in the tumor board rounds regularly and routinely and diagnose and involved in patients' care and management all the time with my oncologist. So, but people and usually the medical students, they always have apprehension as, if I'll be a pathologist, I'll be sitting in a darker room, like a radiologist, or I'll be sitting in my own silo. But that's not the case. We interact a lot, and we guide. We play a central role in the patient management, in patient care, and we help our clinical colleagues. So it is, trust me, it is a very, very exciting specialty to choose. So this is the GI biopsy was done, and this is the example of a colonic polyp. As you can see, this is a scanning power. It's very proliferative, and basically for our pathologists who are here in this meeting, they'll appreciate that you see those adenomatous changes. You see on the left-hand side, left top of the image, you can see that this area is more white and purple versus this area is more bluish purple. It's darker. So basically this is the example how the colonic polyp would look under the microscope in a 20x power on the digital scan slide. So this is again a colonic polyp. If it's a scanning power diagnosis for us as pathologists on microscope, it is same scanning power diagnosis that you can easily make on the digital pathology platform. So this is a slightly higher power. You'll be able to see that how crisp the technology of digital pathology is. You can easily diagnose your cases using this technology. This is the example of GIST. GIST is gastrointestinal stromal tumor. It's a spindle cell lesion. And so this is a scanning power. As you could see, this is the proliferation of these spindle cells. If you go on a higher power, basically the two red circles that I'm showing over here, you can see how crisply and how sharply you can look at the mitosis, because in GIST, we have to give our clinical colleagues, and according to the College of American Pathology tumor protocols, we have to report the mitotic index and the mitotic rate in 5 millimeter area. So that's how we do, and it makes annotations quite easily, and basically you can look your cases very effectively on digital scope, and you can see how the mitosis look like, and these are the spindle cells or the lesional cells for the gastrointestinal stromal tumor. The other thing, we stain our tumors with special markers, which are called the immunohistochemical markers, the IHCs, because we wanted to make sure what the spindle cell lesion is. Is it a leiomyoma? Is it a smooth muscle cell tumor? Or is it, this is a tumor of this interstitial cells of Cajal, so which is the gist? Or is it something else? Or is it a melanoma? So we follow our algorithm and see what is the staining pattern like. So all these immunohistochemical slides are also scanned. So once we see, okay, so if the tumor is positive for CD117, CD34, and c-KIT.1, if it is positive for that, it is GIST. If it was positive for the bottom image, Desmin and SMA, and negative for the rest, we would say this is a leiomyoma. If it was negative for all of them, but just positive for S100, possibility of a melanoma. So basically, this is how we do. So with this digital pathology platform, we can actually put all the slides together with just one click of the mouse and see the co-expression. We as pathologists, we basically put one slide, then we put two slides together, and then we try to, we mark our slides, this is positive, this is negative. So back and forth we go a lot. But with this digital pathology platform, you can actually put all your slides together, just select control and select all these images together and see the co-expressions of these immunohistochemical markers, and to make or ease our diagnosis. So that is a saving time, part of it. Like it saves a lot of your time instead of going back and forth on the microscope. This is an example of a scanning power of a malignant melanoma. It's a skin malignancy, one of the most common malignancies, and very deadly as well. So with the digital pathology platform, you see there's a lot of proliferation. So on the right hand side, where I've written peripheral margin on the top, this is that superficial rim is the part of the normal skin, but actually you see that this is all the proliferation of these malignant neoplastic cells, and which has these brown pigments as well. So this is very infiltrative, and going into this bottom screen where the white part is actually the adipose tissue, so it's infiltrating down there. So the main point over here is basically you can do exact measurements, the peripheral margins, because we have to give certains how far it is, how far this melanoma is from the margin, from the deep margin, from the peripheral margin, is it ulcerated or not? And then what is the thickness of it? You can actually give exact measurements on digital pathology very easily. We do that on the microscope as well, but you have to do a lot of conversion, whichever power you're looking at it. And then we as pathologists, we get interrupted many times by the lab staff, by the secretaries, by our other colleagues as well. Hey, Dr. Memon, can you look at this slide for us? So you'll just take that slide out of the microscope and you put the other slide under the microscope, and you lost your site which you were looking at it. You can't say no to your colleague, you can't say no to other people, but you get interrupted a lot. For the digital pathology platform, I can look at one screen, and then if I'm looking at the other case of my other colleague, I would actually just go into the other case. I can open the second window and minimize this, and I won't lose this information. So it's that effective. So this is a higher power of this melanoma. In melanoma, we are supposed to give the mitotic count in about 1 millimeter area, but of course in the 8th edition for the pathologist, it's too much information. For the undergrad and the medical students, too much of information. But if the pathologists are here in this talk today, so as we all know that the 8th edition of AJCC classification of cutaneous melanoma, mitotic rate is no longer used to distinguish between the PT1A and the PT1B category. However, mitotic rate is still an important prognostic factor. So higher mitotic activity correlates significantly with reduced survival. So we all struggle with counting the mitosis. So you can actually see the bigger circle over here, and the very top of the screen, you can see that I've made exact 1 millimeter area square. I found the hotspot. Hotspot means the area where you're seeing the maximum mitosis. So, and then I've counted all my mitosis, and you can give the exact number. So that is the amount of the accuracy you can give your clinical colleagues and to prepare your final pathology reports. This is a higher power of it as well. You can see how beautifully you can count your mitosis in this platform. And then this brownish pigment on the left-hand side, as you're seeing, this is the pigment for the melanoma. Of course, I did all the staining as well, but not it was required. So just the 2 stains, that's 100 HMB 45 was enough for me. This is the actual peripheral margin status. You can see how precisely 0.643 millimeter, how precisely you can give your margin status using this platform. So it's quite easy. So all these are my real cases that I worked on, and these are all my cases that I have, and they're still there. So all these annotations are still there. If I wanted to remove it, one click of the mouse, the annotations are removed. So if I wanted to go back, or someone else wanted to go back to my case and see it, they can see these annotations. If I wanted to remove it, I'll remove it in one click. So lymph node metastasis, again, for pathologists in this talk over here, you can see on H&E, you can appreciate the lymph node metastasis on the digital platform as well. So, so over here, this blue circle is basically showing you that this is the lymph node, and then over here you can see there is micromets. And this was a case of the breast cancer. Now, this is a very busy slide again. This is invasive colorectal adenocarcinoma. And on the right side of the screen, this blue circle with many, many dots and many, many numbers are basically, I'm looking at the tumor budding. And I found the hotspot where there were maximum tumor budding. And I did the tumor budding counting using this platform. So this is the example of the colorectal cancer. So higher power of the same tumor budding focus, as you could see that for the tumor budding, this is the right hand side is the image from the CAP, College of American Pathology synoptic protocol invasive colorectal carcinoma, as you need the 0.785 millimeter square area. So you have to find that area. As you could see, the very top of the screen, 0.785 millimeter square. So I was so precise on this platform that I can actually find the hotspot and then do my tumor budding counting. And basically you're seeing the single cells infiltrating in this busy, inflammatory, and invasive tumor background. So, so this is a tumor budding, and again, for my pathologist colleague in this talk, and also for the potential medical students who are interested in see how exciting pathology specialty is, and you can actually work. If you're very good with computers, you can actually nail this specialty, and it's so you can provide the tumor budding because it has the prognosis. It gives clinical colleagues and information if there's no lymph node metastasis. If you see that, you find there's a possibility that they have to go after nodes and they will find lymph node metastasis as well. So so tumor budding is usually done on H&E, and so just for today's talk and today's interest, I'm showing that you can actually see how beautifully you can see it under the immunohistochemical markers, but the counting needs to be done on H&E. This is the gastric biopsy. Let's switch to the normal part of it. As you all know that gastritis, we as pathologists, we always get asked, is there any H. pylori, Helicobacter pylori-like organism? So you can easily appreciate on the left-hand side, the pink and purple images, the hematoxylin and eosin stain, the H&E stain. And the top circle, which I'm showing over here on the left, the pink and purple, you see these fuzzy little microorganisms. And if you go on the right hand side where it's written 40X, this is the Wharton starry skein. And over here you can see these black organisms. These are actually the seagull appearance, and these are your H. pylori, Helicobacter pylori. And if you see that, of course, you're going to say that, so this is gastroenteral tract mucosa with findings of chronic gastritis. They are positive for Helicobacter pylori. And then the patient gets treated with the HP pack and gets treated, because H. pylori has the potential of causing gastric cancer if not treated, and they can go to develop gastric maltoma, and so it has consequences. So basically, you're providing that important clinical information to your clinician. Let's switch gears. My favorite part is hematopathology. So this is a lymph node core biopsy, and over here, this is how biopsies we get, and you can see all the lymph nodes. Of course, one has to know a lot of for medical students. Once you know all your histology, once as you know that this is my eye, this is my nose, this is my lips. You know all these parts. So similarly, for pathology as well, you just have to know how the normal tissues they look like under the microscope or on digital or in your books. So you just have to see what the normal look like. And then, if there is anything abnormal, we train you and teach you during the residency training. And basically, this is how we say these are neoplastic, these are inflammatory, these are malignant, these are benign. That's how we do. So this is an example of a diffuse large B-cell lymphoma. So you see this is the higher power image. Again, you can see on H&E, hematopathology, lymph node slide, which was, a patient presented with enlarged 67-year-old female presented with lymphadenopathy, lymph nodes enlarged. And they did a core biopsy. And of course, when you look at it, this is not the normal, because these are very neoplastic, with high NC ratio and atypical with apoptosis, these little pycnotic nuclei, and a lot of mitosis as well. And so basically, this was an example of a diffuse large B-cell lymphoma. So I did all the panel of the diffuse large B-cell lymphoma, which we use for the immunohistochemical marker, like the one that I showed you on the GIST. So similarly, we have our own algorithm, and for each malignancy and for each lineage, we have different immunohistochemical markers, and that's how we reach the diagnosis. But of course, then you order all the molecular markers, and which are prognostic significance, and then you provide that clinical answer to your colleague, and the patient gets treated and get the chemotherapy, radiation based on what the diagnosis is. This is a bone marrow biopsy. Again, my favorite part. This is not a very, quality-wise, not a very good biopsy, but this was my recent case. I'm sharing that diagnosis. As you can see over here, the top part is the blood, which shouldn't be there because the quality is not adequate. The pink lines that you're seeing over here are the actual, the bone, and these are the bone marrow spaces. So as you can see, it's very hypercellular. Again, the patient age is 84 and presenting with anemia and thrombocytopenia. And over here, you can see this is a bone marrow biopsy. As you can see, the marrow spaces are infiltrated by these neoplastic cells, and they have plasmacytoid look. And over here, these fried egg appearance type, bigger pink and purple things are your megakaryocyte, which are the which are the platelets precursors. So basically, this is not a normal marrow. And for our hempath colleagues or the pathologist over here, they can see how effectively and efficiently you can appreciate that under the digital pathology platform. So the bone marrow biopsy, of course, we wanted to do or run all the panel and to give the lineage and to see what we are actually looking at. So the top panel, the brown part, it shows that it is positive. The gray part shows that these cells are negative. So over here, it is CD138 positive, positive for CD117, kappa restricted. So this is an example of a plasma cell myeloma or a multiple myeloma, which is a very common malignancy, hematological malignancy in the bone malignancy. So when do we defer to glass? As I showed you that I still have a microscope. I have a microscope because I do aspirates. Aspirates are the liquid part of the smears that we prepare from the bone marrow to examine patient cells. And similarly, the peripheral blood smears, they're on the slides as well. But now we also use a technology which is called cellular vision. You can actually, it's automatic, computerized. You can actually look at your peripheral blood films very effectively on the actual cellular vision platform as well. So when do we defer? There are possibilities when I defer, and I actually have to ask to pull out glass slides. So glass slides are always available for me whenever I need it. So if the image quality is not good, if it's not scanned, the tissue is so small and it's very fuzzy despite of all the measures that were being taken. So there are limitations. Yale-Nielsen stain, which is for acid-fast bacilli for Mycobacterium tuberculosis, because I don't want to miss those tiny organisms. I still pull out my glass slides and look under the microscope just to see if I'm not missing anything, if these organisms are missing. Fractured bone, sometimes it gives a 3D appearance, and so basically, it's not in one section of plane. So basically, they're in different planes, so it gives that sort of appearance. So I have to look under the microscope, because there was no condenser that I could use on the digital pathology platform. But they are making a lot of good changes as well. Congo red staining, I have to look for amyloid in amyloidosis. So for that, I need a polarizer. The digital pathology platform that we're using doesn't have a polarizer. So you have to see those apple green birefringence, which will only be possible and can be seen on the polarizer. So at that time, and for crystals, I have to pull out my glass slides and look it under the microscope. So how often? It depends on the pathologist. To 1 to 15% of the cases where one or more slides are reviewed prior to sign out. So if this wouldn't be in our case, or all our pathologists are working most of the days from home as well. So we have a very, very lovely and a balanced lifestyle. Believe me, we are 9 to 5 people. And hardly we get called. And if we are called, we are only called on that particular day when we cover a frozen section. If there is a need, you go. But pathologist lifestyle is the quality of the life that we have. Of course, the amount of the study that we do during the residency is hard, but the after freedom that we have, and the knowledge that we get, and the work-life balance, and the family time we can give is amazing. So, and then especially with the advent of the digital pathology, you can even sit and work from your home office workstation, do your consultation, do the dictation using the voice recognition. The voice recognition that we use is a dragon voice recognition. And so you can basically effectively, conduct your meetings, carry out your appointments as well, and do the clinical work and the service work as well. So, the deferral of the glass slide is not a huge problem for us, because if there is hardly, I would say in the last month, I only pulled one glass slide, because of the 3D appearance of the different plane of section of the bone fracture that I had. I just wanted to make sure that I'm not missing any cells, which was a little bit fuzzy on the digital platform, as there is no condenser where I can go up and down and look at it. So most of our pathologists, they would come to the department once or twice a week, or once necessary when they're on call, and then you can work remotely very effectively using this platform. Digital pathology and artificial intelligence, they are married. And so DP is a perfect platform for AI. So in order to run artificial intelligence tools, you need to have all these slides in a scanned platform. Then only you can plug and play these artificial intelligence tools. So AI, artificial intelligence is best for cancer, because it can detect minute focus, which can be missed on the sectioning or on the initial microscopic examination. It improves the diagnosis. It's faster. It's important in grading and scoring, molecular biomarkers interpretation. So the fear that many pathologists or other clinicians like, oh, once you have AI, we don't need a pathologist. That's not the case, my friends. So it is false. It will assist us pathologists for faster and more accurate diagnosis, but it will not replace us. That means we are acquiring all these technologies. You get an iPhone, you get a smartphone. So, that it still needs you as a person. So iPhone is not going to replace you, but still you need this technology, and it's becoming more and more sophisticated and more user-friendly. Nowadays, we don't have to, we can do so many things. There are meetings from using our phones as well. So similarly, AI is a tool. It helps, and it will help pathologists to make faster, more accurate diagnosis, and it will save our time, but it will not replace us. So it's in this fast-paced world, it will help us. So we are getting more and more sophisticated and more robust with this technology, and it's assisting it. So don't shy away from any technology, and don't say, oh, if AI would be introduced, the pathologists won't be needed. They won't have any jobs. No, our job market is really, really good. And be it in Canada, be it in US. So, once you finish your residency, once you get into this beautiful specialty, being gold standard and being physicians, you really get smart, good jobs as well. And the lifestyle is amazing. So back to AI, the US FDA has approved PAGE prostate protocol, the first AI-based pathology product to receive de novo approval from the FDA. So anything that gets approved from FDA is a big thing. So it allows in vitro diagnostics using product to assess pathologists in detection of prostate cancer. So PAGE, you can look up on your search as well to just see, and they're also in my references as well. So PAGE AI platform, basically, so they have PAGE prostate suite, they have the PAGE breast suite, and the digital biomarkers that are also coming, and this will allow in patient stratification and treatment plans as well. So the work in progress in our department is so digital pathology is an essential platform for AI. So our goal at Mackenzie Health and our department chief, Dr. Andrew Evans, is working day and night on that to bring the AI into routine practice. And we are evaluating PAGE prostate tool for actual and for using patient care. Right now, we are testing and trialing that in Gleason scoring, screening biopsies for prostatic adenocarcinoma. This will just make our diagnosis much faster. So PAGE 2 for metastatic breast cancer and lymph nodes, ITC and micromets, we are exploring that as well. And we are also looking at the Visualfarm Ki-67 estimation and mitotic count, where we are waiting to validate that as well. And for the vet hematology, where I'm and the bone marrow aspirate, the hematopathology side of it, which I'm the lead pathologist in our department. So we are actually testing and trialing and basically exploring more softwares to see if there is anything that we could use and available in the market for the peripheral blood smear and for the bone marrow aspirate digital whole slide imaging scanned platform. For now, that's still the work in progress. So we are in the process of establishing the digital consultation network with other hospitals and also access to subspecialty consultations nationally and internationally. So I would like to thank our senior leadership, Mr. Altaf Seshanwala, Richard Tam, Amir Sohaili, and Jim Serjanias, our previous chief, Dr. Desette, Dr. Evans, and the rest of our pathologist team, our lab management team as well, and our skilled pathologist assistants and histotech, the LIS support team, the IT support team, and our vendors, Philips and Epic, the LIS, the laboratory information system that we use. These are my references, and thank you very much. If you have any questions, I'm more than happy to take, be it any baby question from any of the medical students, for the potential candidates who are interested in applying to pathology. Please ask any question. Don't shy away. Put as many as questions you want. You can put it in the chat box. You can raise your hands, ask questions. If you don't want to put your video on, don't put your video on, just ask questions. I'm more than happy to answer any. Thank you so much.
Thank you so much for this talk. I'm Robin. I'm a PhD student at Johns Hopkins. I work with TeleShadowing, so I'll run the Q&A session. Would you say that your organization is kind of ahead of the curve as far as this technology, or is it being adapted pretty much everywhere now?
Okay, that's a very, very good question, Robin. So basically, we're the first in Canada that is using this technology, and and other than that, in Montreal, there's SHRM, and in New Brunswick as well. But for the primary diagnosis, we are the first in Canada using this technology. But
that's great.
yeah, so I think the adoption will take but it, and many institutions, I'm sure, in US are using digital pathology. But so far, from the Canadian side of it, we are the first who are the pioneers in using this technology.
I think we might have a hand raised.
Sure. Olian?
Yes, hi.
Hello.
Hi, Dr. Memon. Thank you so very much. It was very interesting. I am from Houston, Texas, and my question is regarding about the beginning of the using artificial intelligence. So as a pathologist, then you are using the glasses slides when you actually review at least 10 slides for each patient. When you are using artificial intelligence, my knowledge is that you will not be able to review all of those slides. You actually choose one slide to give to the machine to make the WSI. So part of the confusion for me is that how do you choose the slides that you choose the glasses slides to give the machine for having the WSI, and then is that the pathologist, after you have that WSI, is that the pathologist that make the annotation and then the slides and choosing the region of interest, or the machine is doing that by itself?
Okay, Olia, so there are two parts of the questions that I understand, and you can interject anytime. So for the WSI, the whole slide imaging platform, which is, the digitally scanned slides. So all our cases in its entirety, they are scanned. So for example, a prostate needle core biopsy will have from part A to H or I and J, so 10 parts, and would have, 10 parts and 3 slides, A1, A5, A10. So basically, you're looking at 30 slides in prostate needle core biopsy. If it's a prostatectomy specimen, then you're looking at, somewhere, if you're doing a representative section submission versus you're doing a complete, it depends on the size of the prostate. So you're looking at somewhere 70, 80 slides. Similarly, if it's a breast double mastectomy case, post-neoadjuvant chemo, or if it's a breast needle core biopsy case. So breast needle core biopsy depends on how many biopsies it's obtained, 3 to 5 slides based on the levels that each of the department will have based on their protocol. And if it's a mastectomy case, you can have as many as, 50 slides, 100 slides. So in our institution, all the cases are scanned, irrespective of everything. And we have dedicated slide scanning team, which are our histotechs, our MLTs, medical lab technologists. They have done the course and certification in digital scanning. So that part of the training was provided to them. So they'll scan everything. So all my case, if I have a patient, so for example, in my list, I have 50 cases. So each case, if I would just go, it is integrated into our laboratory information system, EPIC, that we use. So it's connected in that. I will click on that link and all the slides will open. So I would say, okay, this case has 10 slides. So I will be able to see. So it's my duty to look at every slide. So we don't cherry pick which slide to choose for WSI platform. So as a pathologist, if the cases come for or conventional or for all the pathology practice right now, it comes in a tray form. Okay, this case has this tray. So, 20 slides, 30 slides, 40 slides, whatever, or just one slide based on the biopsy. So you basically look at it. You don't want to miss, we don't cherry pick anything. So everything gets scanned first thing first. So we look at it and it's, the annotation and all those things are done by pathologists, right? Because we have that knowledge, we have that training, and we are certified to do that. So it's not by the histotechnologist. The AI tools for those as well. So we are using we are testing and trialing right now. And we will go live soon once our department chief and our lab management and our administration team, we do all the validation along with the pathologist, then we will be using that platform. So for those to run the AI algorithms on that, we have to choose the slide of interest as pathologists. So it's my job to choose the slide of interest and I would run, because not all of them will have cancer. Not all of them would, I will have difficulty, in grading one of the things. Oh, shall I call it 3+4 or shall I call it 4+3 in terms of Gleason's scoring pattern? Or is there, a minute focus which we are missing? Or, you can apply all these on that. But, the robust part of it in biopsies, our plan is to screen all of them. And, just one click and you will be able to see all the area of interest on the AI, for example, in the page AI tool as well. So this is how we do. But the annotations and all those things are done by pathologists, but the artificial intelligence tool, so basically once you hit play, you'll be able to see all the hotspots and it will give you a preliminary report. But we as pathologists, our job to actually look at it on the whole slide imaging platform and to see that validation. Do we believe this or not? Or, is it true or not? Because, at the end of the day, it's our responsibility and to produce all these reports and to give final diagnosis for a patient. I hope I answered your question, Alia.
Thank you. Thank you so much.
Okay. Okay, I see another hand. Benga or okay.
Yeah, Benga.
Benja, okay. Hello.
Hi, good morning, everyone. Thank you so much for this session. Really appreciate the effort. I, as an aspiring pathologist, hoping to match very soon. I remember doing one of my clinical rotations. My topic was actually on digital pathology, and I had to, as an IMG, coming, to digital pathology, learning about it. I don't know anything about it. I had to go online, scrapping information here and there. Eventually, I was able to put something together. But of course, no experience. So listening to your session, helped me to dot all the I's and the T's, and I really have an understanding of, even though I had a presentation, I think it's now I really understood what I presented clearly. Meeting with someone that was actually, that is using digital pathology. My department, then, even though it's a teaching hospital, they had not adopted digital pathology. Everybody wants to. But one major problem is usually the financial cost.
Exactly, yeah.
So I want you to share your experience with us. Your department is almost as if you guys are fully digitalized, the department. Have you tried to do a kind of cost analysis? Maybe I know you are just just about 3 years into it fully. Maybe pre-digital pathology days and now that you're into, have you tried to analyze the cost implication? And for those that are trying to transition, because they keep saying, is it worth in the long run? For instance, now you said your turnover time is the same thing.
Mm-hmm.
But does it mean your histopathologist, that support staff, do you need to, you have to train them? Do you acquire more of them? Because I'm just wondering, how do you give them more job to do now, but the turnover time is still the same thing. So does it mean you have to get more of them? Those are my questions.
Okay, so the first question is about the cost.
Yes.
Okay, so since we were opening a newer hospital in 2021, the Cortellucci Vaughan Hospital, so the newer hospitals, we had a lot of funding, we had a lot of support from our administration, from our CEO, and from the government as well, once you open the newer hospital. So over there, so we did not require any RFP. And to be honest, this was not a business case for us with the return of investment point of view. So, once, you should, of course, funding is one of the biggest issue. The first thing is you have to have funding. You have to have enough funding to do this because it's quite an expensive technology to have. But the return on, if you see that the larger side of it, if you see the benefit are way beyond. And, if you do the cost analysis, of course, And if you wanted to hire a pathologist or an expert, and that is, that doesn't have to come on site and work for you. They can even work remotely for you. So there are many benefits that we see. But we were lucky and fortunate enough that our newer hospital had a lot of funding, and so all that was being tackled and taken care at the department, at the CEO level. So we were fortunate and lucky enough to have that part and that piece in place. But I know for many underdeveloping countries, and also for the developed countries as well, with a huge department, the cost is the biggest challenge. And eventually, I see the future is going in that direction. As you could see, there's a lot of resistance that initially every department and every organization will face. I'm sure that radiology had similar kind of challenges. Like, we all used to have old school handheld radiology films that, they would stick it under the light and then you see it. But now you see all their images are on digital. Even you get it on your CD, you get it on your USBs, you're able to see it and carry that. So similarly, I see that the pathology, the future is like that. That's why I said it's so, the current practice should be digital. It's just not the future. But, but I think it's coming, and if the hospital does the proper budgeting, the cost analysis, then it would be much, and see a bigger picture of it, and see how effective and faster turnaround time that could be, and what are the, if you would see what are the benefits of that, the pros of it, then I think it's a great move. But you have to get an RFP and shake and make noise at the bigger level to implement all those things as well. So basically, to be heard, and so that you can embrace this technology.
Thank you.
You're welcome.
Did you have more ancillary steps?
Sorry, any other question?
Yeah, so we have a couple more sort of general questions. What do you think are some of the biggest misconceptions people have about the field of pathology?
Sorry, biggest
misconceptions
of
pathology as a field.
Oh, okay. So, so the biggest misconception is, you would see all those funny videos even shared on YouTube and Instagram sometimes, like, people think that we don't exist, but that's not the case, right? Because they see, oh, send this specimen to the lab. So these are kind of, that's why, when the residents, potential newer residents who are interested to choose pathology as a specialty, or the medical students who wanted to explore pathology as a specialty, they'll say, oh, send it to the lab. So they just think, oh, they'll do the urine test, the tissue diagnosis. And so they just think that the biggest misconception that I personally feel, that people think that we are machines. The pathologists, when they say, oh, pathology department, they just put the tissue, the report will be automatically generated by robots or by machines or technology, and the report will be there. That is a misconception. We actually invest our time. We actually look into the patient specimen. So if it's a breast cancer, it's a big deal for the patient, for the clinician, for the surgeon, for the oncologist, and radiologist, because the radiologist would, the patient would go, I'll just give a simple example. The patient would go to the family doctor's office and say, oh, I feel a lump in my breast. And so this is worrisome, 50-plus-year-old female. So she'll be sent to mammography, and they find, yes, this is a radial scar, or this is, or in the ultrasound, they see a nodule. So then they do through interventional radiology, the biopsy is obtained. It comes to us. So we as pathologists, we make that decision that whether you're looking at a benign thing, or is it just an inflammatory cause? Is it a fat necrosis? Is it actually a benign fibroadenoma, or is it an actually invasive breast cancer? And if it is, we provide them the diagnosis. What is the stage of what is the grading of this cancer? Is it a high grade? Is it a low grade? And this is how we give them the diagnosis. So basically, we are, as pathologists, we are physician's physician. So our end users are the patients, but we report to our clinicians. So basically, we are basically their eyes and giving them the gold standard answer. If we say this is benign, what will happen? The patient will be discharged from the faculty, from the facility. I'm sorry. And if we say it is malignant, the consequence of it is the patient will go and they will book the patient for the surgery. They will book the patient for the chemotherapy based on a report. And then the resection specimen would come and we'll say, yes, it is closest to this margin. No, you have to go back and get more sample from the patient because this patient is not cured. So basically, we are behind the scene doctors. We play a central role in patients' care and management. And so this is the beauty of it. I always wanted to, it's not like I did not match into any other specialty and I chose pathology as a specialty. No. Right from the outset, when I was doing my medical school in Karachi from Dow University of Medical Sciences, I was very interested in pathology. I was very interested. The first chapter that I read in pathology was Neoplasia from Robbins. And that was my favorite chapter. I was really interested in oncology. And I said to Daph, you can either be an oncologist or you can be a pathologist. But when I invested my time much more and more, and I read about it and I said, I really wanted to be that molecular specialist, and I really wanted to give a gold standard answer to my patient as well. I wanted to explore more to a scientific, clinical gold standard answer. That's what we do. So we are behind the scene doctors. The reports, when they are signed out, they're not signed out by just the lab machines. They are signed out by pathologists who undergo an aggressive training. So our internal medicine training is 4 years in Canada, 3 years in Canada, and 1 year is the subspecialty. If you choose cardiology, if you choose nephrology, 1 to 2 years follow-up. Our pathology training is 5 years. It's an aggressive training that we undergo and we do. So basically, the misconception that people think that, oh, you just send it to the lab with there are machines that would do. We are not machines. We are actually the physicians who are looking and putting and investing their time and giving the molecular answer. So all the newer therapies, if the drug would work or not, or the chemotherapy, if we are doing the breast biomarkers for the breast cancer, we say ER is positive, estrogen receptor positive, or PR, progesterone receptor is positive, then the patient would get the tamoxifen. Then the patient would get the hormonal therapy to reduce the size of the breast cancer or to reduce the recurrence. When we say that HER2 is positive, patient is going to get Herceptin, the drug. So basically, we help and assist our clinician, oncologists, surgeons in driving their treatment strategy. So I think, we are integral in medicine. So this is a beautiful specialty to be in. I enjoy every day is exciting for me. Whenever I open the case, it's not the boring job. For me, it's every day is new and exciting. I would just, when I look at it, I unravel unknown mysteries every time, and it keeps my brain going. And for me, the education, the training, the learning, it never stops. I hope I answered.
Yeah, that was a great answer. So pathologists are sort of the hidden heroes of medicine.
Yeah.
I see another hand, so I'll pass it over.
Dr. Param Siddiq.
Yeah, Sadaf, thank you very much. I think we went over time, so I'll just be very brief. Just a comment actually to start with Robin's question about the biggest misconception, I believe, is people think that pathologists are introvert, which I'm yet to meet someone. I think in the older generation, I believe that many of them actually were somehow. And then they're like, we are like kind of asocial, antisocial people, and we don't want to talk to people. We are just sitting in a basement in some black hole. You just throw something specimen out to us, and then magically we'll give you an answer like within hours. And I believe this is one of the reasons that when you get calls from clinicians all the time, like, oh, we just did the FNA from this patient, we just did the biopsy, or can you tell me what's going on? Hey, you just did the biopsy. So there's a whole process that is involved around it, right? It takes hours for the processing and all that. So next day, you'll probably get a preliminary answer, then you run some stains and all that. So and then I get surprised many times. My students, I take a lot of students, and even the students, not IMGs, from US students, and pretty much all over. I think the medical curriculum, how it is, that pathology is not and it's just an elective, right? So as a subject, it's an elective, it's not a mandatory rotation. And then the pathology that we have in our medical school is just the lectures that we go through and all that. So most people are not aware. Sometimes the students get surprised just looking at 10-headed scope or a double-headed scope, like, oh my God, what is this? And so with all that, I think because of the lack of exposure throughout the medical school, people are not aware of it. And then there was a sudden severe decline from the American graduates, that there was about, I think from 2018 to 22, there was about 40% decline in the residency applications from AMGs. But at the same time, to fill that gap, I think there was a severe increase from the IMGs part. So in recent years, we have seen that. But after COVID, I think it went a little bit down, but now it's picking up from AMGs. It went up to 13% again, and I think last couple of years. So basically, I think we should be more vocal about, like, having the pathology as a mandatory rotation during medical school as compared to the elective. So that probably will bring more awareness. But about the overall digital pathology setup, I think great talk. Thank you very much. Really enjoyed your talk, and I think as much as I'm not a tech savvy person, I feel like I'm, we graduated together, but I feel like I'm 10 years older than you. I'm going to be the last person to embrace digital pathology, but I guess this will eventually have to come over. And then, but like you said, the biggest concern, I think most of the people, especially in US, where majority of the practice is community practice, the costs involved, and then we love our microscope. So those are the two biggest things, and then that's going to be a little bit challenging, but I guess it's already there. It's going to come over sooner or later. The biggest issue will always be, like, for-profit organizations. I think this is going to be pretty hard to just go over. Like, for example, in my practice, we are still using Meditech, which is one of the oldest software, because it's a huge funding involved to get to the newer EMRs and all that. So going into digital pathology for that bigger of a setup, where they have 250 hospitals all over US, for example, it's going to be pretty big deal. But I think eventually, once it happens, so far, I think in US, most of the academic programs are doing it. I think MD Anderson is the only one who's 100% digital. But otherwise, it's kind of mix and match. But it will eventually happen, I believe. So yeah, embrace it sooner than later. Thank you very much again for your talk. Really
You're very welcome. Thank you so much for your kind comments and for having me over here. And yeah, all the points that are raised by you. And I know you love your microscope. I love my microscope too, but it's just a comfort. So, they're, technology adopters, in terms of it's how comfortable and how quickly you go. So there's no race. And once you have this technology, and, when you're practicing it, the suggestion is don't look at your microscope at that time. Go blindly, look with a fresh eye, just look your digital images, and then the next day go and look the same thing under the microscope, and then check your diagnosis. That's how you get yourself, basically, comfortable with this technology and develop trust. That's the most important thing, because we as pathologists, the biggest fear is we don't want to miss anything on our slide. We don't want to miss anything which is submitted for the patient. So that's a part of it. So everyone will get there. And and the important point that you raised about making this pathology rotations in the medical school as mandatory should really be brought forward. I think we've in Canada as well, in medical school, the same problems that we have as well. People, medical students would come and do an elective, or sort of, or even if they're coming for their residency, they would just do it. But they have to spend time in order to understand this specialty. And it's a lovely and a very beautiful specialty to be in.
Well, thank you both so much for your insight. This has been a really great talk on an exciting new frontier in medicine. So I invite everyone to give their thanks in the chat. And thank you again for giving us your time today.
Thank you so much for all the lovely messages in the chat box, and I wish you all the best. And for all the medical students, I would say consider pathology. It's a lovely specialty. I hope I have convinced all of you. And then all the IMGs who are interested in applying, wish you all the best in your match and in your future endeavors and curriculum. And thank you for my colleagues as well. Have a wonderful weekend.
Thank you, Dr. Memon.
Bye-bye.
Thank you, Dr. Memon. And now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live. You'll need a 70% or higher to pass and receive certification for this session. So once you pass and take the quiz, you'll receive a certificate. And now on to our next session dates. These dates will all be posted on our social media outlets, so please be sure to be following us at TeleShadowing. We also have a Google Calendar and an email listserv if you want to sign up and register with our program. So our next live session will be on Saturday, June 10th at 10 a.m. Eastern Standard Time for a family medicine and public health session. So it's a different specialty spotlight. Thank you so much, everyone, for attending today's session and making the time today. We hope to see you in upcoming sessions as well. And this concludes this week's shadowing. Thank you.